didn't have, for instance, prescriptions for high-intensity statins, patients who came for PCI or ACS, until it became a quality benchmark. Okay, so it became, so maybe you have to be nice, but maybe you have to also have the ability to spank people. And I think that and I think the issue though that's important is when you do create these benchmarks, these quality benchmarks, that that there be a continuum of education even within the benchmark community, the benchmarkers, so they're keeping up as much with the scientific literature, so as things change. So like really the A1C issue I think is to me is secondary importance to what you're treating those patients with. So if so I think if you're going to modify, it can't just be A1C, but you may say, hey, we think that these patients would benefit, and that's having insurance company not make it so onerous for us to be able to do it. Because I think the nice thing about an insurance company act in particular, because they're really taking they're taking a holistic approach to the patient, because they just don't get stuck with the cost of drugs, but they're getting the cost of hospitalizations, and all these other issues. So you can take a drug which perhaps is not cheap, and you cut a deal with the with the intermediary or whoever, then you probably gain, as we can see on the other end in terms of events. And I'm not an economist, but I think that whereas in the hospital formulary people, they just want to know the cost of drug because they don't benefit from the rehospitalizations and all those issues. So you try to talk to a P&T committee, right? Well, the drug's too much. Well, but it does this and that. Well, my ability to remain employed depends on the pharmacy budget and not these other issues. So the question is, how do you get kind of more of a global approach or a holistic approach to really do what's right for the patient? And before this data with the SGLT2s and GLP-1s, I did not treat diabetic patients. I did not affect glycemic control. I treated their lipids and hypertension aggressively, but so I think it's going to really take in a way also smart moving benchmarks, and I think that that's important. Yes.
I'm curious on the graph where you show the timeline of the 4S and the various studies reported impacted things. I mean, some of that has to play in it too, as far as just decision making on accepting guidelines. Have you seen any change there? Or?
What happens is, I think it's gotten more confusing as you get more guidelines. So you're having so many guidelines. I think most people aren't reading any of them. There's just so many, and although they all have the general theme, low LDLs, one say makes 55 less than, one may say less than 70. You can talk about, look, you get less than 70, you're okay by me. If you like less than 55, then that's even better. But let's go for the low-hanging fruit, right? You saw that some patients weren't even on statins.
Right.
So I think part of it is that physicians are actually a relatively conservative group. We just don't, cardiologists may move faster in some cases because we're used to all these big trials and how it affects, certain therapies. But I think as physicians, we're relatively conservative. I think we don't study. Our longitudinal learning is limited, and I think that leads to a slowdown. And I don't think actually we really started pushing ACE inhibitors and statins as hard until we were penalized. Until we were penalized. So I think unfortunately there will be probably some need, a carrot and a stick. There needs to be the carrot and the stick. I don't think it's just the stick. Yes.
I was just going to comment on what you're talking about, but we are in RAND, and of course the famous McGlynn study in the New England Journal that said there's defect rate in American healthcare of key evidence-based recommendations being followed through on 45%. So it'd be really nice to see where that study is now, but these issues have been around for a long time.
And I think the shortcoming of American medicine, besides psychiatric care, is primary care. I think the Europeans do a better job with primary care, perhaps related to centralized information. I think we do a better job with specialty care and access to specialty care. You can debate on the value of that, but I think that's something where primary care I think still remains in terms of, because they see the patient, they see the patient with a young LDL of young person with LDL 250 who's got familial hyperlipidemia and say, you're young, we don't have to treat it, just don't eat at McDonald's enough. So I think, I think there's a process of education, which at this point the government's not really involved with. The only people who are really involved in education for the most part are the pharmaceutical and device manufacturers. So if you tell people that they can't do it because they're convincing you with a steak dinner that, you know, to use the drug, I think you end up taking away the last, you know, the last approach in terms of regulated information. Thank you very much. Oh, one more question?
Yeah, just in terms of the fish oil, you know, that's an unregulated part of the market. It's a supplement. Is there anything in particular you use to suggest a particular brand or anything?
Not until 3 weeks ago, okay? But now I do. Now I have one drug, rigorous testing. It's different. It's pharmaceutical grade. It's all EPA. You know, if the trial shows the data on a particular drug, I'm going to go by the trial. So I would not recommend prescribing over-the-counter fish oil. You know, I go with the data. It's a pure, you know, EPA, and it's the only agent that's pharmaceutical grade. So my recommendation to my patients is to take the SEPA. Now, if they can't afford it, well, you know, who knows what you're doing with those other compounds, but that's my recommendation. I like to, you know, I like to be data-based, and I don't like to come off the lane unless I'm forced to. So, all right, thank you.
Thank you.
Very informative. Thank you very much, Dr. Lepor. Well, the other part of the Cedars reunion is Dr. Dael Geft, whom I didn't have the pleasure of training with, although I found out today I knew his dad when I was training, so it made me feel a little older. Although you must have been about 30 when I was with you. Dr. Geft is an attending cardiologist at Cedars. He's got quite a bit of experience in a variety of the cardiological subspecialties, but particularly in advanced heart failure transplant cardiology and mechanical circulatory support. So we're going, oh, and the other thing is he was voted Outstanding Fellow of the Year. I never got that award. Is that a new thing?
My dad was on the committee.
Oh, okay. No, I'm sure it was well deserved. So let me introduce Dr. Geffen. He's going to talk about heart failure innovations.
So when Dr. Lepor said, Hattie keeps changing her mind about what she wants, I was really asking him to cover a very broad field. And he did so much, and it was fascinating. We could have definitely had him, you know, as our sole speaker, but we really wanted to address this topic that people are so passionate about now that many of our patients are aging into heart failure, which is first, how do we prevent people from progressing into heart failure, and once they progress into heart failure, how do we prevent them from sliding into you know, the worst outcomes. So he brought with him the wonderful Dael Geft, and we will be learning much in the next half hour from him. Thank you.
Thank you. Thank you so much for really giving me the privilege and opportunity to be here today. I really want to thank you mostly for your location, actually. My colleague was very upset when he has to sit in about 3 hours of traffic trying to get to Orange County at 5 p.m. to give a talk, and I get to go 20 minutes away to the beach. I don't know how you get any work done here, but I really commend you for the incredible work that RAND does, that the RightCare initiative and University Best Practices initiative is really incredible. That's really the way we have to go. I want to try and give an update on where we really stay right now, where we stand in terms of heart failure management, as well as some newer innovations, scanning the entire gamut really from the beginning of the diagnosis of heart failure and just minimal or asymptomatic patients to what our group really specializes in, which is advanced heart failure and things like heart transplantation, mechanical circulatory devices that have to be implanted. I think just as a disclaimer, because that's really what our group focuses on, that's really what we're dealing with all the time, treating heart failure. There's no question that as Dr. Lepor's talk was mainly about. It's all about prevention, prevention, prevention. That's not really what my talk is mostly about, but that's really what is important. But fortunately, there's so much evidence-based medicine behind therapy for heart failure, both medically, as well as device-related on many fronts. And I really want to just go over some of the things that we've known about for years and some of the newer, really amazing things. But I want to start with a little clinical vignette. This is an amazing story, but a real-life patient who actually eventually did become our patient. But I also want you to understand, when you see this sort of dramatic story, this is not an atypical story. This is quite common, and we see this all the time. The gentleman's a 55-year-old guy. He really thought he was basically healthy most of his life. He was very active. He was refereeing soccer a couple of times a week. And he just started noticing some shortness of breath creeping up over several weeks. And he went to his doctor, and really everything seemed to be okay. His labs were fine. His vitals were fine. He did end up getting a chest x-ray because it didn't quite go away. And as many chest x-rays often show, the heart was a little bit enlarged, which led to him getting an echocardiogram or ultrasound of the heart. And lo and behold, his ejection fraction was 20%. EF, ejection fraction, is basically an analysis of how strong the heart is pumping. And a normal one is about 55–60%. This was about 20%, and already the heart was quite dilated. Normal is about 5.5, 5.7 centimeters. This was quite dilated, suggesting that this has probably been going on for quite some time. And here's a guy who was so active, doing everything, had no idea. They followed the usual workup, and he had an angiogram showing no obstructive coronary artery disease. And according to guidelines, and yes, some people, I guess, follow the guidelines, he was started on optimal medical therapy, and there's tons of evidence-based medicine behind all of these therapies, so except for diuretics. But he was started on carvedilol, lisinopril, spironolactone, and diuretics, and did very well. A few months later, he was reassessed, and his ejection fraction had not really improved enough, so a defibrillator was placed. And he did fine for a couple of years. He kept refereeing soccer. He was very active and did great. But about 3 years later, he started to notice, I don't have the same energy. I just feel more fatigued, and something's not right. During that year, he actually got admitted twice. This was the first time he was getting admitted. 2 hospitalizations for heart failure. He needed higher doses of diuretics, and he didn't tolerate the same doses of standard therapy that he had been on for years already. His creatinine, his renal function started to rise a little bit, and a repeat echo showed things were actually getting worse. The function was poor, the heart was still dilated, and the right ventricle was starting to poop out as well. So what next? Well, a lot of people, even doctors and cardiologists, may not know if there is a next, or what more can be done. And so many people would say, well, let's just continue the treatment plan and maybe try not to look at the labs too closely. What about implanting a CardioMEM sensor device, which I'll talk about briefly? And what about referring them to an advanced heart failure clinic? Well, those things didn't happen. One day, he suddenly had a slew of defibrillator shocks and was in VT storm, which essentially is a storm of arrhythmias that are lethal. He came crashing into the hospital. He had to be emergently intubated. He was started on inotropic medication, which are essentially our IV medications to boost the heart function and blood pressure. And a Swan-Ganz catheter was placed to invasively measure his internal pressures in the heart and lungs, and they were, you don't have to know the normal numbers, but these are all very, very elevated, suggesting that he's really overloaded with fluid, and the heart, the output from the heart is quite low. So what now? Well, a very common approach is to panic. The next thing you can try to do is pray. My personal approach is to panic and pray. But the last thing is to really think about the fact that, are there advanced heart failure therapies that are available and real, not just not just ideas of what can be done, but does this really save lives of people who are not just dying but essentially dead sometimes? Well, who are you going to call? The reality is that sometimes it's too late. Sometimes if you're not ahead of the game, you don't know what options there are, you might as well call the Ghostbusters, because they can probably do as much as we can. But hopefully there's hope, and there's time to get them to refer to an advanced heart failure center. It's no secret to all of us what an enormous burden heart failure is, not only to the finances of the country, the government, most importantly, of course, to patients and their families. The most recent updates show we're at about 6.5 million Americans with heart failure, over 1 million new cases diagnosed each year. It's only expected to exponentially grow over the next couple of decades. And we just spent an enormous amount of money on heart failure. And even though there's so many great medications out there with excellent evidence-based outcomes, we still have about a 50% readmission rate within 6 months and 50% mortality within 5 years. One thing I just want to mention as a disclaimer before I continue the talk is about 50% of these heart failure admissions are actually patients with preserved ejection fraction. We're not only talking about patients with very weak or dilated hearts, we're talking about patients with normal ejection fractions or thicker hearts or different types of conditions. And I'll mention that, but the vast majority of what I'm going to talk about today is evidence-based medications or devices for what we call HFrEF, heart failure with reduced ejection fractions. Unfortunately, we really don't have to date any good medication that has really proven that effective in heart failure with preserved ejection fraction, but I'm going to talk about an implantable sensor device which does yield great results even for that population, which is very exciting finally.
Quick question?
Yes.
In the case report that you had, did the gentleman have any risk factors? Because it looks like apparently not.
He actually did,
Oh, he did.
but his only risk factor was hypertension. Yeah.
Did everybody hear that? Hypertension, hypertension, hypertension. Thank you.
That wasn't a setup. I'm not going to go into detail. There's a very long list of all potential etiologies of cardiomyopathies. The unfortunate truth is, most of them, around half of them are related to coronary disease. And so obviously whatever we can do to limit the risk of cardiovascular coronary disease, it's so essential so we don't end up with end-stage heart failure. But more than half are actually what we call non-ischemic cardiomyopathies. These are not related to blockages in the coronary arteries. And many of them we really don't identify any particular etiology. We call it idiopathic essentially. But it's very crucial to think about certain potential etiologies that are reversible. Because when we don't have an etiology to reverse, we basically treat everyone the same way more or less and hope you see the benefit. But things like alcohol, drug-related cardiomyopathies, those things can be reversible if you catch them early enough and you get them to stop. So what can we do for our patients? Where is the evidence base? Well, it's really quite amazing that we have so many trials going back to the 70s and mainly 80s, 90s, where a whole slew of trials looking at beta blockers, ACE inhibitors, and ARBs that consistently showed not only benefit in decreased hospitalizations and symptoms, but mortality benefit. And what was amazing really to see though is not just each drug really works, it's each drug works on top of the next to confer additional mortality benefit on top of the next. And so while a lot of people are saying, well, if I feel good, why are you adding medications to me? Why are you going up on the dose if I feel fine? Because there's great evidence if you can get them on these particular drugs, the mortality rates significantly go down, as well as their hospitalization rate and clinical picture. And not only medication, we're also talking about the addition of defibrillators, we're talking about the addition of CRT, which is cardiac resynchronization therapy, which is the addition of an extra wire to your defibrillator that goes into the heart and helps to more synchronously help the left ventricle contract when there's an asymmetrical contraction.
Sorry to interrupt you, I know you're in a hurry, but it looks like when you add that extra wire, you're reducing, so I'm sure that's not,
Yeah.
I must be reading it wrong.
No. In this particular case, they're looking at these particular medications, education, anticoagulation. There's not really that much a huge difference between the two, but in reality, it's not just this. There's other medications. Spironolactone is not included here, for example. I don't think the addition of in the trials that they've used CRT on top of ICDs, they've shown additional benefit. So We should all be pretty familiar, at least most cardiologists and internists are quite familiar with the current paradigm. And the current paradigm has stood for many, many years now. And as I said, there's great evidence behind it. Even when someone is asymptomatic, you diagnose them with a low ejection fraction. That's when ACE inhibitors, ARBs, and beta blockers need to be initiated. Not only do they need to be initiated, they need to be titrated up to the highest doses you can tolerate, even if you're feeling well. That's a difficult concept sometimes to get patients and doctors to understand. They're feeling well, why are you giving me more medication? They're resistant to that. But there's tremendous data behind that. If they become more symptomatic, then we see the benefit of adding things like spironolactone, or again, ICDs or CRT. And if they're still yet symptomatic, or they can't tolerate ACE inhibitors or ARBs for various reasons like renal dysfunction, isotyl hydralazine, digoxin, these are still things that can be added. And unfortunately, there's still a number of people that get to the end stage where you have to talk about transplant or mechanical pumps. But we do have two exciting new kids on the block to talk about, which is really great, and they've already made their way into the guidelines. And one of them is sacubitril valsartan combination pill, which I hope you may have heard about already.
We really haven't, so
Okay,
maybe we'll have you come back and elaborate on that.
Yeah, I will.
If you don't have time.
I will. This is really, really late-breaking news, and I'll tell you why in just a second. But we've been using it now over the last couple of years with great effect. And the second one is a medication called ivabradine, known as Corlinor now. And it's another drug to add to the armamentarium that has really shown benefit, and I'm going to talk about them right now. Well, when it comes to treating heart failure, again, specifically for reduced ejection fraction, but a lot of these principles apply to preserved ejection fraction as well. We have to really think about it as a cascade of neurohormonal events going on. Adrenaline surge on the heart and beta receptors. The renin-angiotensin-aldosterone system that involves the kidney, retention of fluid, retention of salt, vasoconstriction, and high blood pressure. All of those are what the body really does to compensate for a weaker heart and for someone who's going into heart failure. So really what we do with our therapy is we look at those mechanisms, we try to target them and block them. Block those mechanisms so that these negative remodeling effects and these negative mechanisms over time don't let your heart get worse and worse. Well, we have beta blockers for blocking the sympathetic nervous system and adrenaline, etc. And then we have ACE inhibitors, ARBs, or mineralocorticoid receptor antagonists like spironolactone or eplerenone, which block the renin-angiotensin system. And by doing that, you try and block all of these negative effects of vasoconstriction. But there's another pathway that we really didn't look at until now, and that is the positive effects of natriuretic peptides. The body releases natriuretic peptides. The most common one we measure is BNP, which you may have heard of, called brain natriuretic peptide. But these natriuretic peptides actually circulate and have beneficial effects because they promote vasodilation. They lower the blood pressure, they lower afterload reduction, they lower blood pressure, they increase diuresis, they take the load off the heart. But there's a compound known as neprilysin, which actually breaks down natriuretic peptides to their inactive parts, so we can't get the benefit from them. So what we have now is a combination medication. This is sacubitril with valsartan, known as Entresto, which has the cute little name of ARNI, and it's an angiotensin receptor neprilysin inhibitor. So it's blocking this pathway and blocking this pathway. And of course, we knew that Arnie at some point would be beating me back. He sent me back.
How is he related here?
Arnie Schwarzenegger.
Sorry, just a little slow here.
No problem. Now, this really was an incredible landmark study, the Paradigm-HF study. Why? It's one of the largest single drug heart failure study. Came out, just came out a few years ago. About 8,400 patients with reduced ejection fractions. And what's amazing about this study, this was not a drug against placebo. This was up against enalapril. This is the standard of care. And now ACE inhibitors for so many years with so much evidence behind them. They went head-to-head with an ACE inhibitor, with, at the time it was called LCC 696, but of course now we know the name. Not only did it show it meet its primary endpoint of reducing cardiovascular death and hospitalizations for heart failure, it did so early enough, and they met pre-specified endpoints, that they stopped the trial early. They actually stopped the trial early because they saw such a benefit going up head-to-head against what was already the standard of care for so many years in ACE inhibitors. And it wasn't just the primary endpoint, even the individual endpoints of deaths alone, heart failure hospitalizations alone, they also met statistically significant reductions, which was really amazing. So, here's one of the new kid on the block that's really got a lot of press and is really starting to become more and more used and more comfortable with physicians and patients. Someone had asked the question earlier about why does it take so long to get things into practice? Even when things are approved, it takes time to get them into practice because you're so used to using drugs. You're nervous. What are the side effects? How are patients going to tolerate it? And so it even takes, it took us time to start using it and believing in it. Another thing that I want to talk about is the role of heart rate in heart failure. Is it cause or effect? It's well known that a lot of patients in heart failure, especially with reduced ejection fractions, have a faster heart rate. Well, is that just a bad sign that they're trying to compensate for having a weaker heart, so they have to have a faster heart rate? Or is having the faster heart rate actually also making them worse? And if we could...
I'm only pointing to my Apple Watch because I'm always checking my heart rate now. And I've learned so much about what changes my heart rate, and they're very, very significant. So this is something where we could teach patients maybe some things that could help them avoid or be more alert that something that they need to see their physician if their heart rate is
Yeah, it's true. I mean, those watches are really, for good and bad, they're starting to get into use. We also have the opposite end of the spectrum where people are coming in every second and complaining, well, my heart rate went up to 85 a second ago. Should I come in and see you? It works both ways. But you're right. If we can have people take a little bit more control of their own lives and watching what happens to them. Although this is not to say that people with normal hearts can't be busy all day with heart rates in the 80s or 90s. It doesn't mean that's a detrimental effect. This is specifically in heart failure patients. And we already know that the incredible benefits to beta blockers, one of the effects of beta blockers, of course, is to slow down the heart rate. But beta blockers have other beneficial effects in blocking adrenaline and the sympathetic nervous system. It's not only about the heart rate. So this is a drug called ivabradine. It was already approved in Europe before here, but ivabradine, by working on the sodium funny channels, it actually is able to slow the heart rate without affecting the blood pressure. Many people on beta blockers can't get to a maximal dose because their heart rate's already 50, 55. You can't push it anymore. But this does not, or their blood pressure is very low. You can't push it anymore. This does not affect the blood pressure. As a matter of fact, it may even raise it a little bit. But in their landmark study, the Shift trial, these had to be patients who had low ejection fractions, a good number of patients included, but they also had to be on maximally tolerated beta blockers to begin with. That could have been very low doses for some people, could have been very high doses for some people, but what's interesting to me is look what they considered a fast heart rate. Anything above 70, they were included. I don't think anyone here, most doctors would be very happy if their patient came in with 75 heart rate and think that's good. I don't have to push it. But actually that's who they included, not just people who are tachycardic, for example. And they did meet, again, their primary endpoint, which was a composite of cardiovascular death and heart failure hospitalizations, heart failure deaths and hospitalizations. However, it was mainly driven by heart failure hospitalization reduction. And therefore, in the guidelines, there's now a 2A recommendation to use ivabradine in patients who are already on maximal beta blocker but still have a heart rate above 70 for the purpose of lowering heart failure hospitalizations. And there she is, by the name of Corlenar. Now, anyone who has had to treat heart failure in the community or as outpatients, it's not very easy to treat sometimes. People can start to By the time people present and complain to you about symptoms, it's often too late. They often have to go to the emergency room. You're playing catch up. There aren't too many signs necessarily that things are getting worse.